Thank you for having me today. So we have a pain clinic here, and you have, this is actually off the Kimball website. You have Dr. Lauren Girk, myself, Dr. Sam Sims. I just go by Sam, or you can call me Dr. Sam, whatever you want, whatever you prefer. And then she goes by Jess. I've been doing pain management since 2009. I've run several pain clinics. We took over the role of the pain clinic here just a couple months ago. We run 5 different pain clinics in 3 states right now. So we're very busy, and we also understand the need for pain. So we're specialized in that. And we take what I like to call a multi-specialty approach. We're going to work with your primary care provider. We're not going to change your medications. We're going to offer you procedures. We're going to do assessments on you, see what kind of pain you're having. We're going to refer you to physical therapy. A lot of people just need to go to physical therapy. Physical therapy does cure a lot of people or help a lot of people's pain or reduces a lot of people's pain. And insurance requires you to go to physical therapy too. So we work with your physical therapists. They give you stretching and exercises. So we're going to recommend that. Massage therapy, chiropractic care. But I have not put one surgeon out of business yet. So just be aware that I will try to keep you from having surgery, but surgery may be your final destination, the most appropriate next step. So we just go a stair step. We start at one spot. If that step becomes is successful, we stay there. Once it's not successful, we have another option, and another option, and another option. Sometimes the last option is surgery, and sometimes we go back and we're dealing with post-surgical pain as well. So, I'm sorry, did I miss something? Okay. When you come and see us for a new eval, we will do a full assessment on you. A lot of times we have pain in one area, we'll have pain that's being masked in another area. And so what we'll do is we look for multiple pain generators. Sometimes you'll have pain in your neck, but your hip also kind of bothers you. We take away the pain in your neck, and you're like, man, my hip is killing me. And like, yeah, remember your hip was actually kind of bothering you a little bit before. You can only experience so much pain at once. It has a kind of a ceiling effect, or I like to think of it as a cup of water, right? You guys are all drinking your coffee. A cup of water can only get so full. If I pour it completely full, it's completely full. If I pour more water in there, it's not going to get any fuller, right? And pain's the same way. Once it's full of pain, any more pain that tries to get in that cup, you're not going to experience it. I take the pain away, and that pain that was trying to get into that cup, now you might experience it. So we do a full pain generator assessment on you, and so it can help maximize your care. Low back pain, we deal with that a lot, is the second most common reason people go to see their doctor. And we bend over 20, I think that says 20,000. Oh, it's 2,000. Some people probably do 2,000 to 4,000 times a day. So it's really common. So that's what we deal with a lot. And so this is just one of the spots here when you come and see us. You know, hey, I'm having pain in my back right here. It might be your L5S1. And so we kind of assess you and see where your pain is actually being transmitted. And he lets us know where we need to treat your pain. Sometimes we do injections in the spine. Sometimes we have those little joints called facet joints. Those help support our spine. Sometimes we inject little nerves around there. We assess your pain and see what's most appropriate and where it's happening. It could be a worn out disc. Could be a nerve pinch. Could be something. It could be you need an epidural. You may need something different than that. But we deal with a lot of back pain. And so that's kind of one of our little guides here. You come and see us and we'll say, where's your pain at? Now, obviously that overlaps where the hips are. So you could have hip pain and back pain. You can have a pinched disc right here. You can have this SI joint have arthritis in it, and your hip joint can have arthritis in it. And so we're right here to here, and all these different spots can cause pain, and we're 5 inches apart, okay? And not one injection yet cures all of those. So when we're wearing out in one area, we tend to be wearing out in another area. So sometimes one injection will cover it, and sometimes we need different approaches for each symptom. So these are some of the common things that we will offer. Starting with the head, if you have headaches, we can, or you have dystonia of the cervical spine, we can do Botox to help out with muscle pain, headaches. We do epidural steroid injections. The facet joints, we really don't inject the facets much anymore because now they have these, what's right underneath that, you'll see it's medial branch blocked. That actually supplies the nerve to the facet. It's a sensory nerve. And we find if you have facet joint pain, we can actually go down and burn that nerve and shut that pain down because it's just sensory. We can shut that pain down. 6 months is industry standard, but the product we have here, we're getting, some people are getting 1 to 2 years worth of relief. So that's why we want to make sure we're doing the right thing for you. Most will do that. That's where the radiofrequency ablation comes in. That's where we burn the nerves. I'll talk about that in a little bit. They have a new product called iovera. It's called cryoneurolysis. It's where we freeze nerves. It's part of the No Pain Act for Medicare, so it gets reimbursed well. And Medicare lets you do it every 91 days if you need it that frequently. Some people get relief for around 9 months with an iovera treatment. So we're really happy about that. Nerve blocks, nerve impingements. We do joint injections, trigger points. Trigger points are little muscle bands. I'll talk about those in a second. Other things that we can add in other facilities. PRP is something we consider bringing on here. It's platelet-rich plasma. Whenever you have an injury, your platelets are the first thing to show up, and they tell your body, hey, it's hurt right here. Okay? They release these enzymes that tell your body to stimulate stem cell growth. They're pro-inflammatory. They actually tell your body just to release chemicals to help you heal yourself and to feel less pain in that spot. Well, if you cut yourself, there's a little bit of platelets that show up right there. If I draw platelets and I spin them, then I can do a high concentrated dose of your body's natural ability to heal yourself and inject it back where you're at your area of injury. And it basically tells your body, this spot got ran over by a semi-truck. We got to spend some energy healing this area. So it's really kind of cool. So something we can consider add on out here. Ultrasound guided procedures. So we do anything else, or ultrasound, or we use X-ray. We do PRP. We do PRP. So we always think about growth and expansion. We're always looking at different ways to help and treat people. So if we do a Botox for headaches, this is just an example. We do Botox for other things, but these are the areas that we treat for Botox. Okay. Now it's 31 injection sites. Do you need 31 injection sites? You might not. And so what I do is I actually give mine with numbing medicine. So if your headache goes away at injection 10, we don't have to do the rest of them. Okay? So if you do it without numbing medicine, then you'll end up doing 31 injections. So it depends on your symptoms. If you have cervical pain, we can't do a couple of them. Like the cervical paraspinal one, it's not safe to do those. So you just need to be aware of what's it safe to do, what's it safe not to do. So people who have chronic migraines, this is something that we can do for you. This might be something that some of you are interested in. Joint pain. We can inject all kinds of joints. And so here's a list of all the joints we can inject. We have our clavicle right here. Has 2 joints on it, one on the sternum and one attaches to the shoulder blade. Our shoulder joint we can do injections on. We can do injections in the elbow, hand joints if you have arthritis, hips, knees, toes, feet, SI joint like I already mentioned. So if you're having these joint pains, we can inject those areas too. This is a trigger point. It's a muscle band in your body within that muscle, and it's just a sore spot all the time. You just can't. It's this little tight little nodule that just won't release. And you'll go to the chiropractor sometimes, and some chiropractors will do what's called dry needling. They'll put a needle in that muscle, and they'll keep that needle, that muscle will spasm, and then they'll spin the needle, and it will spasm again, and they're basically just trying to get that muscle to just completely fatigue where it relaxes. What we'll do here is we'll actually go and put numbing medicine and steroid and make it relax immediately and just shut that down. Okay, so if you have those sore spots that just don't go away, you go to the massage therapist, just hurts, we do a lot of trigger point injections. And we usually use a little bit of steroid with them. You don't have to use steroids. Sometimes you can just use local, but steroid decreases the inflammation response in there. So a lot of times we use steroid. So when we're doing our assessment on you, we're going to look at different areas of your body, where the nerves are coming from your spine, and where it's transmitting the nerves. So because sometimes the pain is coming from your spine as they immediately leave your spine, or it's an impinged nerve after it leaves your spine. It's somewhere it's getting pinched along the pelvic rim, or somewhere it transferred through a fascial plane, or you had surgery, or you had an injury, and your body just, when it healed, it adhesed over that area. And as we get older, those things can just happen. So we can look at where the pain is coming from to see if it's something that we need to treat from the spine or more distal. Distal means out, sorry. From the spine, and see if we need to treat where the actual impingement is. So this is what Iovera is, and hopefully the commercial will play. They filmed the commercial, and I'm obviously not an actor, so you'll be able to tell that right away. So this is what we talked about, Iovera. It's approved for, or cryoneurolysis is cryo means cold, lysis means it adheses, it freezes the nerve. So Iovera freezes the nerve at a negative 80 degrees Celsius, okay? And it actually disrupts the axon. There's a sheath that surrounds the entire nerve, doesn't damage the sheath. There's an axon that transmits a signal. That degenerates and then regrows, okay? And we care about that because, one, the nerve is not actually damaged. It shuts down the nerve for 90 days to 9 months, okay? You have to get below negative 100 degrees Celsius to permanently damage a nerve. We use we numb you up. We use nitrous oxide. Nitric oxide boils around negative 80 to negative 88. So because your body temperature is higher than that, it literally can't get colder than that. We can't actually damage the nerve. So it's really, that's the advantage. It's a very safe procedure to do. It can't get colder than it can't get to negative 100 degrees Celsius. So we can't actually permanently damage the nerve. So it can be, and then this is, we'll see if the video plays.
Yeah, so use the mouse and
Okay.
there you go.
Hi, I'm Samuel Sims, a certified registered nurse anesthesiologist in the pain clinic. And I'm excited to tell you about an innovative way to treat pain using focused pull therapy with the Iovera system. Everyone is familiar with the idea of using pull for pain relief, but Iovera uses pull like no other therapy. It is a type of treatment known as cryoneurolysis. The handheld device uses a small needle to deliver precise, controlled doses of cold directly to targeted nerve, which immediately stops pain signals from being transmitted to the brain. All of this is done without the use of drugs or medication. The procedure is complete when the targeted nerves causing your pain are blocked. Unlike other treatments, Iovera does not permanently damage the nerve or the surrounding tissue. Here at the pain clinic, we use the Iovera system to treat osteoarthritis knee pain and pain associated with a total knee replacement. We also treat pain in the head, neck, shoulder, rib, spine, hip, foot, and ankle. To learn more, please visit iovera.com.
All right, you guys are the first ones to see it. That is going to be on, I believe it's going to be on the Kimball website pretty soon. So, okay. So the nice thing about Iovera, it's approved for any sensory nerve. So anything that doesn't transmit motor, anything that when we move as our motor nerves, our sensory nerves transmit pain. It's approved for any sensory nerve. So we can treat headaches with it. We can treat post-mastectomy pain with it. We can treat phantom limb pain with it. We can treat people's ankles with it. The other thing that's really nice about Iovera is we can actually pre-treat if you're going to have surgery. And so we can treat the sensory nerves around your surgical area and decrease your opioid consumption and improve your physical therapy after surgery. So let's say you're going to have both your knees done, but you only qualify for one at a time. What we would do is, if you have two bad knees, we'd come in and we'd actually do Iovera on both knees, because we're going to get this knee that's going to have surgery and you're going to need to have physical therapy. But then you have your other bad knee that's going to have to help you for 90 days, right? And so we decrease the pain in that knee as well. So then you have your surgery on your knee, you get your physical therapy, 91 days later you can have your other knee done. We can then repeat Iovera on that knee. We shouldn't even need to do it on the other knee. We can, because sometimes people have post-surgical pain. Then we can repeat it on that knee, and then you can have that knee surgery, and then now you have a good knee, that you already got repaired, and then you can have your bad knee fixed as well. So it's really good for anything that's immediate if we can also capture it on the other side. Let's say you decide, I don't want an Iovera, and then 2 weeks after your surgery you're like, I wish I would have done that. You can come back and we can do it then too. So we can capture it on the other side of it. So there's two options. Beforehand is always better if your insurance will let you do it, and if you're Medicare, they should just be approved and should be good to go. If you're not Medicare, then there's usually some extra steps, and sometimes we capture it on the back side of it. And that's why we work with your physical therapist, because your physical therapist is going to know, hey, this person's really struggling with physical therapy, okay? And so we can say, okay, we can then recapture on the other side. Or your patient, your family member gets in a car accident and they break all their ribs on one side and they're having excruciating pain when they breathe. We can actually treat rib pain with Iovera. It's one of the few things. We used to do blocks for rib pain, and it would work for about 6 to 8 hours, and it would kind of shut it down for a little bit, but then it would come back. Well, this can shut down people's rib pain for 90 days, sometimes even longer. So it's a huge advantage. And because especially with rib pain, because if you breathe, when you can't take any breath, you're a higher risk of pneumonia. So post-mastectomy pain is something we can treat as well. So, do you have a question? Okay, so that's the Iovera, the cold treatment. And Iovera is nice because it's immediate, but it doesn't always last as long. Okay, so we have to basically decide where are we at? Where are we looking for immediate relief because we're going to have surgery and we need pain relief in this short window, or are we looking at, is this something that is a chronic condition and we need longer term relief? And Iovera is also approved for any sensory nerves, so there's certain nerves that I won't burn, but that's where we get to the next step. This is where we can actually burn nerves. Okay, when we burn nerves, we actually numb up these spots. You come and see us. We say, hey, my knee's been hurting me. It's been hurting me for 6 years. I can't have surgery, or I don't want to have surgery, or I had a patient who she's taking care of her mom. She's like, look, I cannot have surgery right now because I can't be in a sling with my shoulder for the next 6 weeks. So we burned the nerves on her shoulder, and what we do is we bring you in, we test it. We numb up those nerves, and we give you basically a test drive. Go and see how you like it. How do you feel? Do you have less pain? Do you have more function in the day? If the answer is yes, then you're a candidate for radiofrequency ablation. So then we've isolated and identified the nerves that are causing the problem. We've shown by doing a diagnostic block that you get relief if those nerves are treated and you have less pain and improved function. So then we bring you back and we burn those nerves. And when we burn them at the opposite end. We burn it at 880 degrees positive Celsius. Okay? And what that does is it creates a scar on the nerve. We put a blister on it, then it creates a scar. And it takes a little longer than Iovera because it's not immediate. We numb it up, but it takes 6 weeks for it. Just like if you got a cut, it takes time to form. You get an injury, it takes time to form a scar. It's the same thing. It takes about 6 weeks. Usually within a week you're starting to feel better, and every week you feel a little better after that. And then the relief for these, industry standard, like I said earlier, is 6 months, and we can repeat them in 6 months. But for what we're finding, especially around the knee, is we're getting pain relief for 1 to 2 years. So you have 6 weeks where it gets better, and then we have relief for pain for 1 to 2 years. So like the example of that patient that I had, she can't have surgery right now because she's taking care of her aging mother. She's like, look, I need this relief. I can't have surgery. So now she has relief for up to 2 years. And if we need to, we can repeat it again in 6 months, which we don't usually need to repeat it in 6 months, but we can. So it treats the lumbar back pain, knee pain. Obviously, it's the same facet joints here, cervical spine. If we treat high up on the cervical spine, then we actually hit what's called the third occipital nerve. That's where you get the headache that actually runs up the back of your head and goes to your ear. That's that headache right there. And if it's coming from the facet nerve, we actually can burn that nerve and shut that headache down for 6 months to 2 years. Hip pain, we can burn around the hip. Again, if you've had surgery or you can't have surgery, we can burn the nerves around the hip. We can do Iovera around the hip before you have hip surgery. This is afterwards, or you're not a candidate. And a lot of people have these chronic bursts of pains in their legs, right? Chronic bursts of pain. We can actually burn those nerves and shut that burst of pain down for 1 to 2 years. Now, it's a process to get to this point. You have to show that what they say conservative therapy has failed. You had physical therapy, you've had injections, we've injected your bursa, you've done some physical therapy, and those aren't getting the pain relief that you need. Then we come back in and we do the diagnostic, and then we move forward with the RFA. Because if I do an injection in your bursa and it takes away your pain for a year, well, then you don't need to do this process. If you do physical therapy and your pain goes away and it's tolerable for you, then you don't need to go this process. So we're not trying to push anybody in any direction. We're just trying to offer resources for whatever the next step is if something's not working. Yes, sir.
Are these all an inpatient or outpatient or what?
They're all outpatient. When we burn the nerves, though, we do give you sedation for it because what has happened at this point, if you get to this point, we're going to burn your nerve. You came and saw me, we did your assessment, we went and put a needle on those nerves and numbed it, okay? And then you got up and says, yes, I feel better, okay? And then the pain came back. Insurance wants the pain to come back, unfortunately. So then the pain has to come back, and you say the pain's back, and it decreased my function. So then now what I've done is you're going to come back and see me, and I've already made that nerve mad, right? Now I got to make sure that I got to do it again, but I got to burn it. if I get up here and I do a facet nerve and I get a little bit of medicine and you get a little bit of leg weakness for the day and it wears off after, it's just a little bit, like it feels a little bit weak, but then after the day it will wear off, okay? Not a big a deal if you get a little motor weakness for 6 hours. Real big deal if I give you motor weakness for 2 years, right? So that's always a risk. So when I'm doing the diagnostic, I got to get a dart on the dartboard, okay? When I do a therapeutic, when I burn it, I got to get a bullseye. So what I got to do is I got to go put a needle on the nerve that I've already made mad, right? And then I can't numb it yet because I got to stimulate it with electricity to make sure it's not causing a motor response. And then I take it and I numb it and then I light it on fire, okay? So that's hard to hold still for, right? And there's not a lot of room, so we got to make sure we're safe and we make sure you're comfortable. We have you in a position where you can communicate with us, but it is outpatient. Yep, you come to see me in clinic, it's outpatient. There's certain injections if you see me that we can do in clinic, and certain injections we have to do in the operating room.
Do you do surgeries?
I don't cut anybody open. I do percutaneous, which means through the skin. This is the legalese for the lawyers. I do percutaneous procedures. So I put a needle through the skin and then I treat you that way. But no, I don't do incisions. So no, I don't do surgery. But I am in the operating room when the surgeon is doing a surgery, and I'm at the head of the bed doing anesthesia.
Thank you.
Mm-hmm.
How do you find the nerve?
How do we find the nerve that needs to be treated?
Correct.
Okay. So
That would be when you're sticking the needle in.
that's right. So sometimes what we do to find the nerve is we use nerve stimulation, and that lets us know we're in the right spot when you feel it. The facet nerves are right along the bone, so a lot of the injections that we do require what we call bony contact. Okay, so we actually put the needle on the bone. So all these spots are bony contact. That's where the nerve is, and so bone is safe. In pain, bone is home. You know, it's a safe place for you to put your needle. And so everybody's anatomy may be a little bit different, but the medicine does travel. So we stimulate to make sure we're in the right spot. But a lot of times, like we can do an injection, like certain injections like around the knee, those knee spots, those are next to the artery. That's where nerves need a lot of blood supply, okay? Because we want to keep your nerves alive. So we can actually see the artery, and sometimes we can actually just see the nerve. We use ultrasound, we can actually see it.
Have you had any of these treatments done yourself?
I have not. I have had what's called, I have a clinic where I do platelet-rich plasma, where we actually spin it, and we do those injections. And I have that done in my knees about every 18 months. I got my right knee crushed by a horse when I was in college, and so I've never had that surgery, but I do get PRP injections in it. Yeah.
What percentage or what is the chance of missing something and causing paralysis or more pain?
Great question. Extremely low. You will take a bigger risk to your body getting in your car and driving here and driving home than you will have us do the procedure. Okay, every time you get in a car, you're at risk for a car accident, correct? Somebody else on the road could hit you. Okay, driving on the road is more dangerous and more likely to cause a nerve injury than something that I'm going to do. So something you do routinely every day is a bigger risk than what I do routinely every day. But we don't live in a risk-free world. But that's why we do everything is safe and there's precautions. Mm-hmm.
You're taking the pain away, which sounds wonderful. But the underlying condition, if you don't have any pain, is there any chance you're going to make things worse because you don't have pain and you're still doing whatever?
We're taking that. Yes, that's a good question, right? Because pain, there's a reason for pain, right? We put our hand on a hot stove, we're going to pull our hand away, right? We're not going to take the pain away at that level. We're going to isolate the area that hurts. Right, so we can do like a carpal tunnel injection. Right, we'll inject the pain, we'll decrease the pain around the carpal tunnel. You'll be able to have increased motor and function in your hand. We don't take away your ability to feel. Okay, we treat what's called the nociceptors, or those immediate pain responses. But we don't take away that completely. It's not like you're going to walk around with like a numb hand or anything like that. You should be able to feel just that isolated nerve. You may have a little bit of numb spots. That can happen, but it's not going to it won't take away that deep pain.
But the place that's hurting, if there's something wrong with that place, and you take the pain away.
So that's why we do X-rays and we do images. So let's say you come and see me for back pain. One of the things I'm going to do is I'm going to say, I need an MRI or a CT scan of your back. Because if I don't get that, what if you have a tumor in there, right? So you have a tumor in your back, and I just inject it and I take away your pain for 6 months. Well, without knowing, right? Then I have given you an inappropriate procedure, okay? So that's why we do X-rays, to make sure, hey, there is no tumor, there's no risk, there's no cyst, this is not a surgical intervention. Okay, so that's part of the evaluation, part of the everything. So we actually look at that to make sure. Because certain things are surgical interventions. Yep, sometimes we have to send people to surgery right away. You know, if you tore all the ligaments and tendons off your shoulder, I'm not going to fix that with an injection, right? Now, you may not be a surgical candidate, and I'm able to just be able to decrease the pain around your shoulder, but I'm going to send you to a surgeon. He can say, you're not a surgical candidate. You can't have surgery right now for whatever reason. Maybe you're not a surgical candidate because you had a recent heart attack. Maybe you're not a surgical candidate because you can't be laid up for 6 weeks. You know, he can say, let's see if we can decrease your pain until you are a surgical candidate. It's about decreasing your pain and improving your function. That is the goal. Okay?
So if you burn that nerve, and it lasts for, like you say, between 6 months and 2 years, does that nerve regenerate, or do others grow around and come back in there?
Yeah, so because it's a scar, your body can heal. Yes, your body will eventually heal that. And when it regenerates, it may regenerate with less pain. But yes, it can come back, and that's why it is a procedure that sometimes we do have to repeat. And so we're looking at, if I have 6 months of pain relief, I'll have better life and I'll have better function and I'll be happier. But yet realizing the fact that, like, yes, I want to live that's why we do diagnostics too. Like I said, that's your test drive. You go try it out for a day. If you don't like the way it feels, you don't have to do it. You say, oh man, some people don't like the numb feeling, they get in some spots, they like, I don't want to feel like that. Most of the time, like if I numb up, like somebody who has like really bad ankle pain, and I numb up the nerve ahead of time, and they say, hey, go, take away that pain. 99% of the time, they say, I could live the rest of my life like that, and they want that pain to be gone.
How do you treat arthritic pain?
So arthritic pain, like in the joints?
It's probably not due to a nerve, is it?
No. So there's nerve endings inside the joint, and there's an inflammatory process that actually exists inside the joint. So the joint actually has a sac of fluid, and then it has inflamed tissue. Okay, and that inflamed tissue causes what we call impingement. Okay, and so what we do is we go in there and we give some medicine, and over the next 7 days we give some steroid and we give some local. The local kind of calms everything down, and then it opens up that inflamed tissue. Okay, and it gives you a little bit more room in the joint to move around. That's how we treat the osteoarthritis pain. But there's also mechanical pain. You can have what's called bone on bone. Okay, you can have inflammation and bone on bone, and sometimes those injections will really work. Okay, you'll decrease your pain because you take away the inflammational pain. Mechanical pain is fixed with stretching, physical therapy, and surgery. If you have just mechanical pain, then you're going to have those are things that are going to fix it. And sometimes when physical therapy fails, stretching fails, injections fail, then it's all mechanical, and you need to see a surgeon because it's bone on bone. There's no inflammation there, so that's how you fix that. But I have people that we kick the can down the road kind of thing. I have a lady we kicked the can down the road for 3 years, and then all of a sudden the injection stopped working for her. She wouldn't have had her hip surgery. She didn't want to have it before then. A lot of surgeons want you to have these injections, and a lot of insurances want you to have these injections to show that they failed before you just jump straight to surgery.
A friend of ours is having his second open heart surgery, and from the first one, he realizes the worst about the surgery is the back pain.
Mm-hmm.
From spreading the ribs, so what should he do about that pain pre-surgery?
It'd be interesting to see if you could. It's the back pain, because what happens is they cut your chest open, they cut your sternum, and when they spread it, those ribs push here on your back where they connect to your spine. That's what my original training was, open heart. It'd be interesting. I'd have to look. If they would allow it, Iovera would be a great choice for him. where he could actually go and they could freeze those rib nerve pains along his back, if they would allow it.
Are you saying Ivera or Ivera?
Iovera. I'm going to go to one more since now we're talking about what we can do. So this is pretty much everything we do in the pain clinic. Just a few things, yeah. No, it's not drugs. That's right.
That's great.
Yeah, we're a non-opioid pain clinic. Yep, we're looking for procedures to give you long relief.
How often do you come to Kimball?
So between the three of us, there's one of us here every week. One of us is doing it. We have 2 pain clinics at evals, so I'm doing evals today. And I can do there's some procedures we do actually do in clinic. Some insurances allow for that. We're here at least twice a month doing clinic, and we're here at least twice a month doing just for procedure days. I have made sure that every CRNA that comes here has been trained on Iovera, so Iovera can be done any day. So it doesn't have to necessarily be me. It can be one of my another provider. So if it's added on at the end of the day, there's that tight window around surgery. So if your surgery is scheduled, you have to have it within 20 days plus or minus. So basically 11 days out or 11 days after. Otherwise, insurance won't pay for it. So if you're going to have surgery in 3 weeks, then we want to get you that tight window. We want to get that. We have a 7-day window. We can get Iovera. So we want to make sure that we do it within that 7-day window. So any CRNA that comes here at the end of the surgery day, they can just add it on and just do it for you. I know it's a lot.
Other questions?
Do we make an appointment with you, or do we see our family doctor and they handle it?
You could do either one. Yeah, you can just call the pain clinic and you can make an appointment. We can go. I'm going to just back it up to right here at the beginning, where that number is right there.
Yeah. Just call the clinic number, the 1966 number, and any one of those gals can help you and get you set up.
So do you go to the clinic? to see-
Yes.
Okay.
And you'll see one of us. Yep.
I'm seeing you.
Well, thank you. That's very kind of you to say. I will tell you that Dr. Lauren and Dr. Jess are amazing. Dr. Lauren actually does injections on my wife. I've known Jess for a long time. I will let them take care of any family member of mine. So I want you to know if I'm not here, you're going to get a provider that I would feel comfortable doing an injection not only on myself, but some of my family and my kids.
Well, and if you've had a surgical procedure here anytime recently, you've probably seen one of these folks in the OR. You just didn't realize
Yeah.
they were taking care of you there as well.
Now, the ones that require a hospital, you can do here?
Yeah, we can do everything. On that list, we can do everything here. Yep, we do it all. We own the machines. Yeah, we were doing them yesterday.
Yeah.
Yep.
Yeah, the foundation just helped purchase a new Avanos, which is an RFA
Yep, radio frequency. Yep.
machine. So they have the latest and greatest to utilize there as well.
Yeah, I think it's the only machine that's FDA approved for the major joints. So it's the one we can do. We can do the shoulders now. We can do the hips, the knees. So it's, and then the greater cotracheic bursts. So and we're seeing with that we're getting the longer results.
Tell us about that machine.
The radio frequency ablation machine. That's the machine that's where we burn the nerves. It's a generator that we actually put the needle in. We actually stimulate it. It's connected to the generator, make sure everything's safe, and then that's where it stimulates and actually heats up the end of that needle.
For spinal stenosis, if you have multiple sites done, is that one done with fluoroscopy then?
It'll be done with fluoroscopy. We see what area is causing your biggest pain. I a lot of times will do with spinal stenosis. I have two approaches. There's 2 approaches to the spine, basically. You can go in from just one shot in the back, or you can go individual nerves from the side. This is called the interlaminar approach. This is called the transforaminal approach. I like to call this the shotgun approach because it's one blast, hits everything. Okay. And I like to call this one the rifle approach because it's individual shots. Okay. They have not shown that either one is superior. It's just for certain people, one shot works, and for other people, multiple shot works. So what I do is I almost always start with one shot because you'll be mad at me if I poke you 4 times and it didn't work, and I say, come back, let's try 1. So I don't do that. I try one, and if one doesn't work, they say, well, let's try the other side. Let's try the multiple. Now, if it's discogenic pain, like this disc right here, in that research, they actually do really do well a lot of times with a transforaminal approach to start.
Can you help with
Huh? What's that, sir?
Can you help with neuropathy?
So peripheral neuropathy, that would be something we could. Yeah, there actually is something now, and I will have to talk to if we can bring that on board. It's called Qutenza, and we have already broached the subject. We're going to make sure it's. But with peripheral neuropathy, it's actually the same thing as actually burning the nerves, except we do it with a capsaicin paste. And the capsaicin paste, it's a pad. You actually, what we'll do is if we bring it on here, it's kind of a new product, so not really anybody has it. You know what I mean? So we need to get a rep out here. We got to look at financials and all those other kind of little fun little pieces. But you can look it up. You might be able to find a place in the meantime. Maybe they might do it in the big cities at the point. I wrap your feet in lidocaine, okay, a lidocaine patch, make your feet numb, and then I take that and I leave that on for an hour, and then I wrap your foot in Qutenza. Now, capsaicin is the spicy stuff in peppers, right? You can buy capsaicin creams over the counter, and it's 0.1%. Okay, so the capsaicin Qutenza is 8%. So it's 80 times. It's a lot. Okay, so that's why we numb your feet up, because it will. And what it does is that capsaicin on your feet actually burns all the little tiny little nociceptive nerves that transmit for peripheral neuropathy around your foot, okay? And that will last about 3 months. So yeah, it is the only thing that I know of that actually treats peripheral neuropathy, and it is a new product. And so we're trying to get some reps to come out here and talk to us, because we want to see if it's something we can actually bring on board, that makes sense for the facility.
Your feet in hot chili.
Basically, yeah, but medical hot chili paste. Medical grade hot chili paste. Yeah. If you don't numb your feet up, it can be pretty warm. I heard somebody that put one on without numbing their feet up, and they lasted about 3 minutes before they had to take it off. So, yeah.
Any last questions? Because I do need to get Sam back to seeing patients, or the nurses are going to be down here having my high.
Yeah, they're going to be picking around the corner.
Yeah. Any other questions?
Yeah, one more. Do you work with a certain surgeon or any of them?
I work with any of them.
Okay.
Yeah, I get along with just about everybody. And if I don't, it's their fault.
Thank you.
Yep.
Well, thank you so much for
Absolutely,
coming.
absolutely.
This was great. I think we've got a lot of great information, and like Sam said, if you're interested in coming in and talking to any of our pain folks, just call the clinic, 1966, and they'll get you set up.